Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case of a 39-year-old patient who came to ER with complaints of breathlessness.
Yes.
Sir, initially the patient was brought
39 or 59?
39, sir.
Lady.
Yes, sir. 39-year-old female. Right now the patient came to ER and we started with the initial 10-second assessment. Airway appears patent, there is no pooling of secretions. Regarding the breathing, the respiratory rate was 30 breaths per minute and saturation is 88% on room air. At this point of time, because of her hypoxia and the tachypnea, we have started her on 5-liter oxygen face mask, sir. Next, going to the next step, the circulation. The BP was on the lower side of 96 by 58 mmHg and pulse rate was 95 per minute, whereas the capillary refill time was less than 2 minutes, less than 2 seconds. So we have, at this point of time, we put a 2 large bore cannulas and we have taken samples for ABG and connected to the cardiac monitor. The heart rate was on the cardiac monitor 95, sir. BP was on the lower side, so started with the fluids at 100 ml per hour. Next, coming to the disability, GCS
If
was
BP
E4.
is low, immediately how can
Bolus
we
the
start fluid?
First, we need to check the IVC and then.
When you are working in a center like this, we have to make sure that it is dehydration. Can be so many other things.
Capillary refill time wise, it was less than 2 seconds, so there was adequate perfusion. But the patient was tachypnic and hypoxic, so that might be like the.
How can you know that fluid is less in the body, or there is dehydration or intravascular volume depletion in this patient? What
First,
are the ways?
we could ask for the signs of the dehydrations, like asking the thirst and seeing the tongue, seeing the skin turgor. And second thing, physically we can use POCUS and see the IVC, whether it is compressible greater than 50%.
Okay.
If it is an IP patient kind of thing, then we can use urine output as an target for us to increase the hydration.
Okay, so that should be done. Otherwise, we are blindly treating the patient. We don't know whether it is dehydrated or something else. Suppose it is myocarditis, tachycardia will be there, hypotension will be there, acute MI, you can have hypotension, tachycardia. So we have to prove it. This is because of the dehydration. Then you have to treat.
Next, coming to the disability, patient is fully conscious, oriented with GCS of E4, V5, M6 and pupils at 2.5 mm equal and bilaterally reactive. Regarding the exposure, temperature was 101 degree Fahrenheit. She is febrile to touch. We had given an injection paracetamol. Along with that, we have given injection paracetamol, sir. Now coming to the adjuvants to the primary survey, we have taken an ABG because the patient was hypoxic and tachypnic. So we have taken an ABG. ABG was showing type 1 respiratory failure with no acid-base disorder, sir. So we continued the 5-liter oxygen mask. And coming to the examination part in the breathing, I forgot to say, like on auscultation, we heard bilateral creps were present. And V's was also present, sir. So we had nebulized with beta agonist, that is salbutamol, sir. Okay. Next, coming to the other adjuvant to the primary survey would be the point of care. In point of care, CBC CRP point of care, we had seen that the CRP was 60, sir. And WBC count is 6.18 with eosinophil percentage of 10.6%, sir, at this point of time. And platelets were 236 and hemoglobin was 10.8. So in view that the patient has come with breathing difficulty, hypoxic tachypnea and the fever was present and the counts are on the elevated side, we consider it to be an infective etiology, and the patient was started on an empirical antibiotic as of now as ceftriaxone, sir.
Okay.
Ceftriaxone was started, along with that even Fluivir was also started, and post which we had sent for all the labs.
What do you think about antibiotic in this case?
In this case, basically patient is having a bronchitis kind of a picture. The X-ray which was taken was showing bilateral infiltrates in this patient. There was no any specific consolidation suggesting of any low pneumonia kind of a picture. So when there are bilateral infiltrates, the first differential would be a viral pneumonia kind of a picture. And bilateral creps were also there, so any fluid overload can also be.
No, it's okay. I'm asking, why did you start ceftriaxone? That's all.
It's an empirical treatment.
It's not an empirical.
Augmentin would be the empirical.
Why you select ceftriaxone?
Gram-negative coverage. If
you are in a community-acquired lung infection, how can you suspect gram-negative infection? Ceftriaxone has got some gram negative coverage, and there are some gram positive coverage is there. That is definitely it is there. But how can you start ceftriaxone in a case like this? Is that
Clinical.
is that correct or not?
Wrong. It empirical wise it is a wrong treatment,
a-
but clinically judging the patient.
Empirically, it is a wrong treatment.
Yes, sir.
Because in a community-acquired pneumonia, what you told viral infection is correct. That may be the most common reason for this bilateral infiltration, bilateral crepitations, rashes all over the body. That is a most common thing. Okay. But if at all, if you want to start an antibiotic, it has to be gram positive, predominantly gram positive coverage. You can give augmentin, you can give amoxicillin, you can give crystalline penicillin, you can give azithromycin, you can give doxycycline. There are a lot of choices. Okay. So unnecessarily exposing all these patients to a third generation cephalosporin may not be very good. But it has got coverage of gram positive. That also we should know. Okay. So it is better to go for something other than this gram negative coverage in acute phase. And later if you come to know that it is a organism which is sensitive to ceftriaxone, then you can change. Okay.
Sir, next further coming to the secondary survey, sir, regarding the allergies, she has no regarding the allergies, she had a previous skin lesions which were present as rashes when she was on ATT, sir.
ATT.
Okay. So coming to the further background history, she had a lymph node TB at 14 years of age, for which she was started on ATT, and 3 months after starting the ATT, she developed certain skin rashes, for which she had to stop the ATT, sir, at that point of time. Next, another past history was she had a deliberate self-harm attempt, and she was having stressors, and she was having psychotic kind of episodes.
Okay.
This is the background history. Right now, coming to the history as of now, present complaint patient had a predominantly dry cough since 1 week, which is associated with shortness of breath and fever episodes. Apart from that, she also certain past history, like 1 month back, she had a left ankle pain, significantly bone pain or left metatarsophalangeal joints, for which certain evaluation has been done in outside hospital, and they had sent an RA factor which has turned out to be positive, and anti-CCP was
So
negative.
tell me something about RF factor.
Rheumatoid factor.
What is that? We get a lot of patients whose investigation done outside RF positive, rheumatoid factor positive, not RF positive, rheumatoid factor positive. What is your opinion about that?
It is not a specific.
Suppose you do rheumatoid factor today without any symptom. If it is positive, what is your inference? What is it? Is that your diagnosis is rheumatoid arthritis?
No, but it is same like the D-dimer. It's positive doesn't make sense, but if it's negative, it is a more specific that absence of a disease is there.
If there is a clinical finding which tells you that this is rheumatoid arthritis, and if it is positive, it has got some value. If it is positive, it doesn't mean that the person is having rheumatoid arthritis. 30% of the normal population can have rheumatoid factor positive. So that's a normal test, and it should be interpreted with only clinical judgment. It should not be an isolated diagnostic test. Okay, you can see a lot of patients, they have some joint pain because of vitamin D deficiency or old age. Rheumatoid factor may be positive. Then that doesn't mean that that patient is having rheumatoid arthritis. Okay, but if it is rheumatoid factor positive, we have to document that, because there are a lot of other diseases, there also rheumatoid factor can be positive.
So in this patient, on evaluation, rheumatoid factor was positive and anti-CCP was negative. Okay. In view of which...
So what is the difference between anti-CCP and rheumatoid factor? Is that same or different?
Different.
It is different, and the test is more specific and sensitive for rheumatoid arthritis, and it can come before the onset of joint pains. So the anti-CCP is a better investigation than rheumatoid factor, and once it is positive, possibly it is positive.
So the outside concerned doctor has started her with, initially she started with Ayurveda, then changed to homeopathy, then started with sulfasalazine drugs. Okay. So this was like 2 weeks back, and the fever started on 26th, which was a low grade fever. Then it was changed into high grade continuous fever, associated with cough for 1 week and breathing difficulty. So she was taken to the local hospital, and one day post admission in the local hospital was referred to us because of her desaturation. In hospital, after a course of 3 days, she started developing rashes over the skin, sir, which was generalized erythematous maculopapular rashes, which pruritus on palms and soles, which further progressed to having edema over face and extremities. In hospital, we had started treating her with nebulizations and empirical antibiotics of ceftriaxone and fluvir. And initial first day, as because wheeze was persistent, we had given a hydrocort 100 mg OD stat, after which steroids were never given. So during the progression of the case, the rashes progressed from the palms and soles to all over the body and to the lower limb. Along with that, the rashes become palpable purpuritic
What is the
rashes.
difference between palpable purpura and non-palpable purpura?
So it helps in differentiating the diagnosis. It's like a palpable purpura can be seen in adult onset stills.
No, palpable purpura is a vasculitic purpura. Most of the other purpuras are non-palpable purpuras. They only show a red spot. If you palpate, you will not see. But whereas vascular purpuras are always palpable. So that like narrows down your differential diagnosis. Okay.
So in this case, there were palpable purpura, and also the patient was having continuous, recurrent fever spikes. And during the fever spikes, there was observation that the rashes were prominent with itching in nature.
What is the importance of hand involvement of rashes? Involvement of hand in all these conditions. Involvement of hand. Huh? Hand is involved. What is it? Because you are in emergency room, you should know this. You get a lot of viral fevers, there are rashes there. You get a lot of patients who is having drug hypersensitivity, there also rashes are there. What is the importance of hand? Huh? You have seen a lot of viral fevers. Have you ever seen that viral fevers other than hand, foot, mouth disease, hands are involved? It is not there. But whereas in vasculitic purpuras, including this DRESS syndrome, DRESS is actually a drug rash. Okay. And adult onset Still's disease, most of these conditions, hands are involved. So this patient is having a fever, viral fever. We should know whether it is a viral fever induced rash or a drug related rash or a vasculitic rash. Okay, vasculitic rash and drug fevers, drug rashes, most of the time hands are involved. Whereas viral, it will not happen. But hand, foot, mouth disease is one condition where the hands are involved. There the rashes are in a different form, not like what you are describing.
So regarding the symptoms wise, the rashes which are palpable, there are pruritic rashes, and other clinical signs were like there was facial puffiness and maculopapular rashes with periorbital swelling and no oropalatal ulcer. So there is no mucosal involvement of the rashes. And on auscultation, there were infrascapular fine crepes throughout the whole time, sir.
Mucosal rashes are common in which type of disease?
Measles.
SLE. It is very classical of SLE. Generalized rash with oral rashes, oral ulcerations. That is one of the feature of SLE.
So regarding the lab parameters, initial day labs showed procal to be negative by 1.19 procal and CRP was 62, and OTPT derangement was there in 214 and 163, sir. But INR was within normal range of 1.13. With WBC count of 6.18 and eosinophils were elevated 10.6, sir. After which the further progression of the disease, the WBC count slightly increased to 30,000, sir, and eosinophil counts increased to 10%. It was holding at the same. Apart from that, the CRP had been the constant throughout the hospital first 4 days. It started with 60 and it stayed around 57, sir. So at this point of time, we have differential diagnosis for the rash with fever and symptoms present. First, most common which we have to rule out was a viral rash because patient was diagnosed with the viral. And second thing, we need to think about the new onset drug rash because she was started with drug called sulfasalazine, the sulfa containing drug just 2 weeks prior to this history. And third thing, as in this case, the patient was having fever. The first adult onset Still's disease because during the course of fever we were seeing the rash was prominent. So individually, the diagnostic criteria.
So finally, you have two differential diagram. One is dress or
and adult onset
adult
children.
onset.
But in this case, it was like to narrow the diagnosis in dress, the ideal criteria eosinophil count greater than.
Initially, it was high.
It was high, that was pushing towards the dress, but the only cons in this case, which we cannot say dress, is the WBC count was on the higher side.
What may be the reason for WBC count? Can it increase in Dress syndrome? Can it increase in adult onset Still's disease?
Actually, count wise, no. There can be leukocytosis and lymphocytosis. In dress, it's usually eosinophil, which we are seeing.
Eosinophil is
And
elevation of eosinophil is goes towards dress. That doesn't mean that the total count can be increased because of the eosinophil count itself.
Yeah, normal leukocytosis can also be in dress, but in adult onset Still's disease, the granular cells which are increased, usually elevated. And in regarding the the common agents which can cause dress, first thing would be the anti-seizure medications like carbamazepine, phenytoin, lamotrigine. Next would be the antibiotics like rifampicin, vancomycin. Next, sulfa-containing medications like sulfametazole, sulfasalazine, and dapsone. And in this case,
sulfonamides, they are also comes under
sulfa. Yes, sir, sulfonamide.
So that is a common sulfa drug which we use.
So these are the causative agents for the dress. And regarding the regarding the diagnostic criteria for the dress, we use the usually symptoms wise, typically clinical presentation onset would be 2 to 8 weeks after the starting of the offended drug, and it is usually delayed onset rather than acute onset reaction. And cutaneous features, there will be one morbilliform rash. It often starts with the face, upper trunk, and extremities. In this patient also, it started with the trunk and then spread over to the extremities, the hands, and then further to the legs. Facial edema is characteristic, which was present in this case. And regarding the hematological findings, eosinophilia is a hallmark, but it is not essential for every case. And atypical lymphocytes will be there. Leukocytosis can also be seen, or even pancytopenia can be seen. Regarding the systemic symptoms, fever greater than 38 degrees is nearly universal. So in the course of hospital, the first 3 days she was having a recurrent fever spikes. But once in view of the consideration of the differential of adult onset Still's disease and the dress, we have started her on steroid. Post starting of the steroid, the fever has subsided. So this is a characteristic response which can be seen in dress. Whereas in adult onset Still's disease, a longer duration of the steroid treatment is required for the fever to subside, is the thing. Next, even in dress, there can be an internal organ involvement. Like in this case, we had seen that the elevated OTPTs were there, which was indicating that the liver was involved. If lung is involved, there can be pneumonitis causing the Krebs and also the dyspnea-like features. Next, if heart would have been involved, myocarditis or pericarditis can be seen, and kidneys, interstitial nephritis causing kidney failure. Regarding the diagnostic criteria, it is called as Reggie-Scar criteria. The major points are the fever, eosinophilia, and atypical lymphocytes with skin rash and organ involvement. Depending on the scoring system of that, we will differentiate whether it's likely to be dress or unlikely to be. In this patient, the scoring system was 5 and it was like a probable dress syndrome. As against to this, in differential diagnosis, we are considering it to be versus adult onset Still's disease. Here in adult onset Still's disease, the onset should have been gradual and immediate onset, like rather than 2 to 8 weeks after the drug, as we have seen in this
adult
case.
Adult onset disease, nothing to do with the drug.
Yes, sir.
It is a different thing. It starts like a viral fever. It starts with fever, sore throat, generalized rashes. But during the fever, the rash will increase. That's how you differentiate between.
And also the rash is called a salmon pink macula.
Same thing like dress also.
Yes. But this is like, wording wise, it's morbilliform rash, and this is salmon pink rash.
Both had ferritin levels will be very high in adult onset. less in
8
dress.
times the normal value is expected in adult onset for diagnosing the patient, and prognostically the lowering of the ferritin level helps us to determine whether the disease is going to bad prognosis or good prognosis. In this patient, the first ferritin value which was taken, which was sent, was shown 2000, sir.
2000.
So after which we started the steroids, immediately it fell to 800, and so
Okay.
the management wise, luckily both DRESS and adult onset still disease both have the treatment first line as the steroids.
Okay.
And for DRESS, usually the initial dosing of the steroids would be on the higher dosing and very short course. Whereas adult onset still disease, the treatment of steroids would be a low dose with a prolonged duration. Within the
In
next
acute catastrophic adult onset, you have to give higher
dose.
Okay.
And in this case, as soon as we have started with the dexamethasone of 16 mg one start dose, the eosinophil count has started dropping, OTPTs have dropped, the rash intensity has dropped, and the facial puffiness, the features have also dropped, indicating that the response to the treatment of the steroids. And sulfasalazine drug has to be withheld because that is the offending agent.
Okay.
Apart from that, last day the patient had even a palpable cervical lymphadenopathy. So in view that the patient had a cervical lymphadenopathy and previously a lymphadenopathy, like a TB lymph node was there, further planned to do a lymph node biopsy and to rule out TB is the due course.
Okay. Lymphadenopathy is more common with DRESS or adult onset?
Lymphadenopathy more common with DRESS.
Lymphadenopathy is more common with adult onset, but it is there in DRESS also. That is a problem.
Okay.
DRESS also you get lymphadenopathy, adult onset also will be get. But adult onset it will be more. But we cannot tell which is more, which is less. We are only we are only seeing once in a while this type of patients.
Yes. So this is the case which we had treated with steroids, and further the patient's saturation wise it got improved.
Okay.
And right now to rule out TB lymph node, because previously she was a known
If the
case.
lungs are involved, severe ARDS is there, how do you manage?
Like ARDS protocol.
ARDS protocol is correct, but what should be the dose of steroids?
High cup.
High cup means how much?
Ideally here the dexa like 40 mg per.
This dexamethasone, if we are giving 40 mg.
Methylprednisolone 1 mg per kg.
1 gram.
1 gram.
So both are equal. Dexamethasone, methylprednisolone, both are equal. Dexamethasone is cheaper. Okay. And its mineralocorticoid action is less. Okay.
Long activity is also.
Okay. So both are equally effective for treating the inflammation.
Treatment, like the price wise also
Dexamethasone is cheaper.
Also, this is the first line of treatment is the glucocorticoid. Second line of treatment, we can go with steroid sparing agents like methotrexate, or we can use biologicals like IL-1 inhibitor, IL-6 inhibitor, tocilizumab kind of monoclonal antibodies. And next adjunctive therapy or third line would be plasmapheresis, immunoglobulin.
Plasmapheresis is used in which condition?
Adult.
In adult onset only, where all you can use plasma. It's an emergency treatment.
Whenever there is multi-organ failure. Cytokinetics.
Plasmapheresis in this condition, when there is a multi-organ dysfunction, patient is going to BOOP. BOOP is lung infiltration, or a patient is having severe renal failure. You are not having time to treat with steroids or biological. Then all these immunoglobulins or plasmapheresis may be helpful. Okay.
Yes, sir.
Anything you want to add? Nothing. Thank you.